Coming to pulsatile bone tumors. When we talk about pulsatile bone tumors, there are some names that you must remember. Number 1, osteosarcoma. Everything else follows it but is not as common. In the order: aneurysmal bone cyst, endothelioma of bone, very rare, and GCT. In many of your books, they have given GCT as number 1. Remember, Turex says pulsatile bone tumor is osteosarcoma. Osteosarcoma is the cancer of youth. Occurs in the second decade of life. It's a radiation-induced sarcoma. It's a radio-resistant bone tumor. What is radiation-induced? You give radiotherapy to a patient. After 10 to 15 years, there is a tumor of the bone coming in that region. Radiation-induced sarcoma. You do a biopsy, it will be osteosarcoma. It's a bone-forming tumor, homogeneous calcification. It is associated with germline retinoblastomas. Less than 1% cases of Paget's, which is also called as osteitis deformans, will have osteosarcoma. Pain, osteosarcoma. Night pain, osteosarcoma. Night pain relieved on taking salicylates. Osteoid osteoma. When you look at radiology, this image particularly, you can see carefully there is a lesion in the bone that extends to the soft tissues, lifts up the periosteum, triangular piece of bone underneath the periosteum. The physis half fused, half unfused. So if we look at the age of skeletal maturity, shoulder is 18 years, wrist is 18 years, knee is 18 years. So this must be around 18 years, a little less than 18 years. So this is second decade of life. Along with that, it's a metaphyseal lesion. Along with that, wide zone of activity. This combination takes you to osteosarcoma. Osteosarcoma can come from the medullary cavity, as we saw, right on the bone, periosteal, coming away from the bone, periosteal, in Paget's or after radiotherapy. Look at this. That's a parosteal osteosarcoma. In osteosarcoma, there is an osteoid formation that causes calcification. That's how the parosteal osteosarcoma looks like. Very common on lower end of femur. Lower end femur is overall the commonest site for osteosarcoma also. But when you have parosteal, it's on the posterior element, posterior cortex. And then treatment. T10 protocol. Remember, you give chemotherapy, shrink the size, do an excision, see the necrosis. If the necrosis is more than 95%, it is chemosensitive. Give the same chemotherapy as the adjuvant chemotherapy. And if the necrosis is less than 95%, change the drugs. This is T10 protocol. Remember, methotrexate is the most important drug. Etoposide is not used. Prognosis. Extent of a disease means staging. More the stage, poor the prognosis. Pulmonary metastasis. It is the most common site of mets, poor prognosis. Systemic metastasis and pulmonary metastasis, both are there. If there is a patient with liver mets and one patient with lung mets, the one with the liver mets will have poorer prognosis. Higher the grade, poorer the prognosis. Osteosarcoma is a malignancy associated with pneumothorax. Why grade is colored? We will talk about it. Coming to one of the commonest tumors that they ask in entrance exams, Ewing's. It arises from the marrow, the medullary cavity. So it arises from the medullary cavity of the metaphysis, but localizes in the diaphysis, involving the femur. Second decade of life, more than the first decade. Pain is a universal complaint. Presence like osteomyelitis. Marrow biopsy in these cases can be useful to see the involvement, because Ewing's is the most aggressive tumor known to mankind. You have to treat it very quick, otherwise it can have high mortality. That is why it involves the marrow and spreads. Presence like osteomyelitis. This is an image the child will present. Tissue diagnostic. Involves the bone and the soft tissue component. Onion peel appearance on the skin, as if the cortex is hazy. Genetic linkage of Ewing's. MYC2 is a specific marker associated with trisomy 8, trisomy 12. There is a translocation 21-22, 7-22. The bigger digit is always at the second point. Ewing's, it's a round cell tumor with glycogen positive cells. The most common genetic defect is translocation 11-22. Remember this. Poor factors in Ewing's. Ewing's is the most aggressive bone tumor known to mankind. Age more than 12, poor. Males, poor. Proximal, poor. Fever, poor. Important point. Anemia, poor. Increased counts, poor. High platelets, high ESR, high LDH, poor. When you look at these points, fever, high ESR, high TLC, they all can be present in osteomyelitis. So when Ewing's presents like osteomyelitis, we are already dealing with a poor prognostic Ewing sarcoma. Metastasis, chemoresistance and relapse, these are the three poorest factors. You know the difference between the prognostic factors of Ewing and osteo? In osteo you had a grade, in Ewing's you don't, because all Ewing's are high grade. Treatment, chemotherapy, followed by surgery, followed by chemotherapy. Radiotherapy is plus minus. Most radiosensitive bone tumor, even then, radiotherapy plus minus. Remember, hazy cortex, onion peel appearance, Ewing's. Second decade, diaphysis, Ewing's. Second decade, metaphysis, osteosarcoma. Chondrosarcoma, the third malignant bone tumor, involves the pelvis. It has dense calcification. It is associated with hyperglycemia. Amongst the malignant tumors, chondrosarcoma will have the best prognosis, followed by osteosarcoma, and the worst is Ewing sarcoma. Coming to the most common primary bone tumor, multiple myeloma. It's a proliferation of the plasma cells. They will give you a history of multiple bone pains, very high ESR, usually more than 100, high calcium. They can have M proteins in urine and serum, the bone marrow plasma cells, or a solitary plasma lesion called as plasmacytoma, end organ damage like bone lesions, low hemoglobin, high calcium, high creatinine, high viscosity, amyloidosis, infections. More than 2 episodes per year is a rate of infection to be counted as a criteria. They have punched out lytic lesion as if there are erosions on the bone. Plasma cell leukemia is more aggressive variety or the end point of multiple myeloma when they have more than 20% plasma cells in the smear. These are the punched out lytic lesion on the skull. Only skull? No. Can it involve the femur? Yes. Humerus? Yes. Ribs? Yes. Vertebra? Yes. Any bone, in fact. When you look at the lytic lesions of skull, this is a mnemonic you should remember at Mel-Thorme. Mel-Thorme has M for metastasis, E for eosinophilic granuloma, L for Langerhans cell histiocytosis, T for tuberculosis, H for rare cause hyperparathyroidism, O for osteomyelitis, R for radiotherapy, again M for multiple myeloma, and E for epidermoids. Remember, the H happens to be a rare cause. When we talk about skull lytic lesion, punched out lytic lesion is the number one that you should remember. It is seen in multiple myeloma. The plasma cell proliferation will cause these lesions. So this is number one. Multiple myeloma, punched out lytic lesion. But then you have beveled lesions, sloping beveled lesions, seen in eosinophilic granuloma, a type of histiocytosis. Another type of histiocytosis can have more aggressive lesions. The Langerhans cell histiocytosis, the permeative lesions. And then you can have ... as if salt and pepper have been mixed and sprinkled on the skull, called as salt pepper skull, feature of hyperparathyroidism. When we look at the margins, I just spoke about permeative margins here. Well, you have a well-defined lesion with sclerotic margins, like a simple bone cyst. Well-defined lesion without sclerotic margins, like aneurysmal bone cyst or giant cell tumor. Or you have the ill-defined lesions, like chondrosarcoma. These are geographical lesions. They have areas. You can have moth-eaten appearance, more aggressive variety seen in multiple myeloma and metastasis. And as they become more and more aggressive, more destructive, you can have permeative margins seen in multiple myeloma, metastasis, but Ewing's, the most aggressive tumor known to mankind. When we look at permeative margins of Ewing's and permeative margin of skull, they are a little different. In skull, permeative means large lesions. So these are beveled lesions, sloping lesions of eosinophilic granuloma. These are Langerhans cells, or these are Langerhans cell histiocytosis permeative lesions. These are salt pepper skull, hyperparathyroidism, very, very rare cause of a lytic lesion, but included so that you can solve the questions. When you look at the other side, they are not lytic lesions, but then we are covering skulls, so let's cover it. You can have dense deposit of calcification called as cotton wool skull, seen in Paget's, or a big area of osteoporosis called as osteoporosis circumscripta, again seen in Paget's. Or you can have hair on end appearance, seen in hemolytic anemias like thalassemia. Of lately, we have got combinations of orthopedics with histoslides, Like here you can see sheets of plasma cells seen in plasmacytoma. They'll give you a history, solitary lesion, spine, pelvis, skull, rib, any bone can be involved. Not a widespread disease like multiple myeloma. There will not be any other clinical feature of multiple myeloma. There won't be hypercalcemia, kidney involvement, low hemoglobin, or any other bone lesion. You will have uniform sheath of plasma cells. Another variety that's coming nowadays, Langerhans cell histiocytosis, eosinophilic granuloma, solitary, or if they want to show Langerhans cell histiocytosis involving multiple system, they'll give you more features. They can present with a skull lytic lesion. The cells will be mixed with giant cells. They will be oval nuclei with the grooves, resembling a coffee bean nucleus. The immunomarkers can be mentioned in some questions like CD1A plus or S100 plus. You will see the tennis racket shaped granules in the cytoplasm, the Burbeck granules.